All right, so we have a good amount of people in here. Let me just see one person. Ronnie, are you with us?
I am.
Okay, just making sure. Sorry, my connection is really bad, so I am going to start off. I'm actually going to turn off my video just so when I share my screen, the connection doesn't cut off. So I'm going to stop my video now, but I encourage our panelists to keep their video on. So, hi everybody, thank you for joining us today for our COVID-19 Health Equity Exploring Disparities in Data webinar. My name is Isra Al-Hawli and I'm a Public Health Coordinator at Access Community Health and Research Center. For those of you who don't know Access, we are the nation's largest Arab American community nonprofit organization. And our work focuses on community empowerment, and we serve diverse communities, not just Arab Americans, in the areas of health and mental health, economic empowerment, workforce development, education, etc. And today's call will focus specifically on racial disparities in COVID-19 infections and death, and what can be done to address these inequities. Our speakers will discuss what data needs to be collected to better understand disparate impact of COVID-19 and how to address these significant and persistent challenges. We will also learn about the All of Us research program and how they are engaging a diverse community of participants across the nation in their biomedical research. And as you know, the pandemic will touch every corner of our health systems, but today we only have 1 hour, so we're going to be very focused on the system inequities and disproportionate impacts that COVID-19 has on people of color. I'm joined today by my co-moderator, Mohammed Ali Itani, and I'm going to pass it on to him to introduce himself and a few of our panelists.
Hey guys, how's it going? My name is Mohammed Ali Itani. I am the president of the Public Health Society. And and we also have two of our other members, the vice president and event coordinator, Muhammad Al Hashim and Race Tate. They're attendees, but I just want to tell them, they're with us here too. So one of our panelists that joined us here today, thankfully, hopefully, will go well. Dr. Muhammad Hamami, who is he's president of the University of Michigan. I know that. He's also the senior vice president for Safety Net Transformation, Community Benefit, Health and Wellbeing at Trinity Health. He leads a strategy to improve health for individuals and improve the underlying social determinants of health and community served. He also works with Trinity Health's community-based delivery models and public health initiatives and partners closely with the state and national experts and integrate the healthcare delivery with public health activities. Also joining us is Beth Niblock, who is the Chief Information Officer, Chief Homeland Security and Emergency Management in the State of Detroit, and a member of President Obama's White House Office of Science and Technology Policy Team that visited Detroit in 2013. Also, she was also appointed CIO by the Mike Mayor Duggan in 2014. Under her leadership, the city employs a wide range of new technology systems, after which residents can report problems, post police, fire, EMS, demolition, and etc.
And I'm going to introduce Madiha Tariq. She's the Deputy Director of the Access Community Health and Research Center, where she oversees health promotion and disease prevention programs focused on immigrants and refugees. Hi, Madiha. And our fourth panelist for today is Ronnie Tet, Principal HCM Strategist. Ronnie has more than 20 years of health policy experience, and she brings a deep understanding of the medical research community and a passion for patient advocacy to her work with HCM. She lends her considerable expertise to healthcare clients, such as the National Institute of Health All of Us research program. As the principal investigator for this project, Ronnie leads and manages a team tasked with reaching, educating, and engaging underrepresented communities in medical research. Hello, Ronnie. Thank you for joining us, all of you guys. I'm going to talk briefly about the All of Us research program. For those of you who do not know, this program is a historic effort to gather data from 1 million or more people living in the US to accelerate research and improve health. The ultimate goal is to further precision medicine in the treatment and prevention strategies that take into account individual differences such as our lifestyle, our social economic status, environmental health, and biology, among other things. And as the largest Arab American community nonprofit in the US, we were very excited to get involved with the All of Us research program. We know all too well that the stakes are simply too high for us to sit on the sidelines of an effort that's not only groundbreaking, but is truly inclusive of all of us. And as you may know, the Middle Eastern and North Africans, MENA individuals do not have their own box on the census. We actually identify as white. And unfortunately, the lack of MENA inclusion in the US extends far beyond the census. This also includes access to quality healthcare and the inclusion in biomedical research, which is something that we at Access are particularly passionate about. And so through this program, we set out to educate Arab Americans both locally and nationally about the importance of their voices being heard, and we encourage them to participate in the program. We are truly thankful for the All of Us research program for trying to bring in a diverse group of people who are often underrepresented in biomedical research. And yeah, so we truly value this partnership, and we're really excited to be included in this historic effort. Before we begin, we wanted to, before I pass it back to Mohammed, I wanted to quickly highlight the data that we're seeing here in Michigan and in Wayne County specifically. As of today, Michigan has reported nearly 59,000 confirmed cases and nearly 6,000 deaths due to COVID-19. Detroit still has the highest coronavirus numbers in the state with over 11,000 cases and nearly 1,500 deaths. And just to give you a better picture and truly understand this data is that African Americans in Michigan, they account for just 14% of our population, but they are also 33% of the COVID-19 cases and 41% of the deaths. What we're seeing today is there are already existing disparities that are heightened. And when you add a pandemic to the mix, you know, these get higher, and COVID-19 has resulted in many lost lives and fear, and this has affected all of us. And in addition to health harms, there's a widespread of social and economic disruptions, and those disruptions harm those of us who are most vulnerable to these inequities. Some people are referring to, sorry, I'm just gonna go back. Some people are referring to this as the crisis within the crisis, and data today reveals that when comparing COVID-19 deaths and cases in counties with higher or lower than average Black populations, we see that areas with the larger concentration of Black people have more deaths and they have more cases. And when we look at the COVID-19 Michigan data in comparison to the Wayne County data, which has a large concentration of Arab Americans, African Americans, and other marginalized groups, you see how these communities are affected very differently due to the social determinants of health, like population density, poverty, the underlying health conditions, and access to medical services. And this data really shows you that there is really no one-size-fits-all approach to combat this pandemic. I'm going to pass it back to Mohammed, who's going to get us started with the first question.
Hello. All right. Dr. Kamami, the first question, well, it's like a two-part question. Hopefully, we'll go to you, and let's get the ball rolling. So the question is, what are the healthcare disparities, And how does COVID-19 highlight these existing health inequities?
Thank you, Mohammed, and thank you, Asra, and happy to be here with such esteemed colleagues on this panel. I think Asra just walked us through whatever needs to be said. Actually, it's quite to the graphs that we have seen, the picture that she painted. But to talk specifically, when we talk about disparities, then it's any difference in maybe the incidence of a disease or the prevalence of a disease or the burden that disease adds to a certain population when it is compared to another population. So there are natural disparities, for example, based on age. Hypertension is probably more in older and people than it's in younger. So this is a natural disparity. But disparities add to inequities whenever the reason is avoidable. So what we want to talk about is avoidable inequities that are based on resource distribution, based on socioeconomic status, based on discrimination, based on unequal opportunities for people to be healthy, which brings us back to a definition of health. And we always talk, and it has been mentioned as well, the social determinants of health. We've always talked about health as a more comprehensive status rather than the absence of disease or the absence of illness. So when we are talking about wellness versus health as I am not sick, then this is where the root causes of any inequities should be looked at. And this is what we attribute to the social status or the social and the socioeconomic factors and risk factors. Which brings us to what happened during this pandemic. It didn't show anything that we did not know. We've always documented that certain ethnicities and certain minorities and people from certain socioeconomic status have a higher burden of disease or their health isn't up to par when compared to others. Take an example, we were talking about Wayne County, but even within Wayne County, when I was the health officer for the county, under my jurisdiction, I had 43 municipalities. Those municipalities included the Grosse Pointes, but it also included Hamtramck and Ecorse and Inkster. And it doesn't take a public health professional or any data analyst to agree that those that are living in the points are not going to experience the same disparities or the same burden for those that are living downriver or in Hamtramck or in Ecorse. So what COVID-19 showed us is it highlighted how in such a pandemic, even the burden of such a disease is unequal when it comes to certain population and certain minorities. I think the only positive thing that this pandemic has brought up is now you hear people on media channels, even in the White House, talking about inequities and talking about disparities. And I think this is a golden opportunity to start talking about that.
Thank you, Dr. Hamami. Our second question is to Mediha. Mediha, you have spent your career studying and working in equity and health, and now we have a pandemic where it's very clear that these illnesses and challenges are affecting different people in different ways. From your vantage point, from working on the ground at various COVID-19 testing sites, what is really important for people to know? What are some of the disproportionate impacts that COVID-19 is having on these communities of color that you have seen? And I also would like for you to just talk a little bit about the work that Access has been doing during the COVID-19 pandemic.
Sure, and I'll start by like kind of giving an overview of what Access is doing. So since the beginning of the pandemic and the shutdowns in Michigan, Access started doing a drive-through testing program. We set it up in the parking lot of our office in Dearborn, and we were focusing initially on, essentially we were focusing on the populations that we were allowed by the state to focus on, because there were such limited PPE and limited testing abilities. So we started by working with first responders and police, health workers, essential workers. And, through our conversations with the state, we've been able to open this up, and now we are doing what we call a drive-to testing program. So we actually go into communities. We have 4 vans that have ability to do mobile testing wherever we go. We just, we've gone to homeless shelters, senior living facilities, recovery homes. We've gone to churches, mosques, community centers, high schools, and most of the time we just set up tents in the parking lot and have people drive through and get tested. Our focus has been, on the hotspots in the Detroit area. As you all may know, Michigan ranks 4th in the nation for deaths, COVID deaths, and 7th in the nation for cases. We really feel that all community centers, need to do what they can to be able to reach the populations that are at the higher risk. And as Asra mentioned, there's about, there are about 60,000, 59,000 people confirmed cases of COVID, and then about 6,000 deaths. So it's important for us to see who those 54,000 people that did not die were, and who are the 6,000 people that died. I think it's very important to reflect on the additional pandemic that exists here, the pandemic that has been going on for the last 400 years, which is racism in the system. And I think it's really important to look at how communities of color and why communities of color are disproportionately affected. And I think some of that has been touched on by my colleagues. But I also think about the fact that there's a lot of communities of color in other states. Why is it that Michigan is rating so high? And one of the things that it's my hypothesis, is the fact that we have a lot of people that work in factories that are essential workers. And a lot of if you look at the population of people that are working, that are essential workers that have to go to work, they can't do what all of us are doing right now, which is, being on Zoom calls and work from home. Those populations tend to be more likely to be communities of color than not. And I think it's really important to take a note of that, because we can't solve that problem in this call today. That requires us going upstream and seeing why certain populations, are able to, for the most part, have certain kinds of jobs, most of which are lower paying. Why certain populations live in neighborhoods that are more dense, or live in houses where there's many people sharing the space because the houses are not big enough. So I don't have a solution to that. I don't think any of us do, but I think it's important to take a second to acknowledge that. The second thing I'll say is that the disproportionate impact of COVID-19 or any pandemic or health issue is also, it also takes shape in the form of lack of data or lack of appropriate data. I have been working with the state of Michigan to figure out, because we serve a lot of Arab American and MENA populations, Middle East, North Africa. And I've been trying to figure out what the rates are for COVID positive and COVID mortality in our Arab American and Chaldean American populations. And the website says I think it was 2% for cases and 1% for deaths. I can tell you that just doesn't sound right. When you look at the hospital data, and I know that a lot of hospitals make a lot of concerted efforts to collect data on MENA, even though that data shows is underestimated. We've been talking to the state to figure out how we can collect this. Right now it's considered granular information because Arab Americans are not a minority, so it's not a census category. So we have to basically disaggregate the white category and have an additional option in order to collect this data. But when you talk to the state, there's a data collection mechanism. So like, let's say I'm filling out an intake form in Papa, Michigan, and I say I'm Arab American. That data can't go anywhere if there's no place to receive the data. So we are actually right now working with the state to see if there's a way for us to create a category in their data analysis program, so that if I'm in Papa, Michigan, and I say I'm Arab American, but in Dearborn, Michigan, there's not a category, at least we can collect this data from wherever people are indicating that's MENA. So that's like from the system side. I think the other thing is talking about, and I think maybe we'll discuss this a little bit more later, but it's also about how comfortable are people in actually identifying themselves as Arab American or Chaldean American or MENA. When I first started working at Access, one of the first programs I led was the Navigator program through the Affordable Care Act. And I remember working with this family in our Sterling Heights office, and they were clearly, MENA. They were clearly from the MENA community. And I asked them, about the race and ethnicity question, and we actually collect MENA data. And they said, no, we're white. Like, don't put white down there. We're not MENA, we're white. And it was really hard for me to understand, what's going on. But as I've become more, familiar with the politics of things and the history of things in our state and in this country, it makes more sense. So it's not just about creating a system that collects the data, but it's also creating a space that's welcoming. And sorry if I sound like an activist right now, but it's hard not to be emotional in the time that we're in. So I think it's also creating that space where people are not afraid to put down MENA. Or people don't think that they're going to receive like less of a service, or they might get approved faster for their program because they indicated that they were white. So it's a two-way street, in my opinion.
That is really valuable information. Thank you, Madihan. Thank you for all the work that you're doing on the ground. Hamid, if you're speaking, you're on mute.
Sorry, I forgot, my bad. I didn't see it. Forgive me. Oh, so next question goes to Missing the Block. Through your work, you made like a #1 priority to test and protect your responders and your essential workers who show up to work every day in the city of Detroit. And through different means, serving Detroit residents has also been #1 priority. And as we all know, as the COVID spreads, telemedicine has been pretty valuable, connecting patients to doctors. So, Mr. Block, could you please tell us, talk to us about the importance of telehealth during COVID-19, some of the limitations, barriers that the Detroit residents have faced in the use of telehealth, if you could.
Well, thank you, and thank you for having me on here. As the only non-healthcare professional on here, I was really, I'm coming at it from a very different angle, and I was really thankful to hear Maria's comments on data collection, because as a person who does technology, one of the things that we've struggled with is how do we capture all the data? How do we make the data as transparent as possible? And how do we, especially as the state is reshaping its contact tracing and some of their other information, how do we make that data granular enough that it becomes helpful and we can kind of be able to analyze data in the right way? So I thank you. I was listening and taking a lot of notes on your comments. I feel like if we all come at the state from various levels and they hear the same thing, maybe we'll be able to impact change there. So anyway, thank you for having me on. And I ended up in this as somebody who just, because I don't take no for an answer. So the mayor put me and my colleague Hakeem Berry in charge of obviously with the health department, as this COVID outbreak was really started to take off, just got overwhelmed. And we knew that one of the things that we really had to focus on was testing. And so in very short order, I learned more about swabs, all different kind of swabs, where the swabs came from, if they're bovine swabs, how long they have to stay under heat to be accepted and get through customs. So it's been an interesting thing. But one of the things that we really focused on, obviously, was our first responders, mostly because we had a very heavy outbreak in our police department, where at one point, almost half of our police department was in quarantine. So we also have medical first responders in both of our firefighters and our EMS units who were having to go into houses and transport people. So we really did a lot of testing around that. But we also knew, I think we also heard from Medea that the criteria for testing was so rigid at the beginning, and I understand why, because supplies were so short. But the mayor really pushed opening testing pretty quickly to a lot of different groups. And so we were able to do that. But the other things that we were, and then I promise, Mohammed, I'll answer your question. One of the other things that we were able to do is understand that we had a significant mobility problem. So once we were able to test people who were symptomatic and over the age of 60, or people who had comorbidity factors and were showing symptoms, we knew we had to have a way to get folks to the testing ground. So we were able to work that out. And then a lot of times you had to have a primary care physician's prescription to get tested, which then we set together a network of PCPs that would write prescriptions so that we could get people to testing as well. And then there's a significant language barrier. So we were able to work with the people who were taking the appointments so that we had our language line on standby, and we were able to focus on Spanish, Arabic, and Bengali. And all of our test results and all of our handouts at the testing center are in multiple languages. So, but the big thing getting to telehealth, I mean, it's so natural to be able to just have the doctor come to you. But in the case of Detroiters, it is a significant problem. To the tune of 29% of Detroit residents do not have any internet access at all. Think about that. 29% of Detroiters do not have any internet access at all. Over half the city does not have an active wired broadband connection. So 52% of our residents do not have a wired broadband connection. And 40% of Detroit residents do not have a cellular data plan. So just think about that for a minute. Folks were really, we put up in the city of Detroit a coalition of hotspots for folks to be able, like at the Rosa Parks Transit Center, the State Fairgrounds Transit Center. The library system would tell you that after hours, they had a lot more connections than they did during hours, because that was people going up to the library, kids trying to do their homework because they had no connectivity at home. So, you know, that's one part of it, that some of that is an infrastructure challenge. But the other thing is there's the whole cost challenge, not only around connectivity, but around the device. Because a lot of people will say, well, a phone is a good enough device to do all this, but it really isn't for a lot of other things. Like if you're trying to fill out your health questionnaire on a cell phone over cellular data, it's just a train wreck because they're not built to handle those kinds of things. The other thing is we've got a real digital literacy and technology gap in the city of Detroit. And a lot of that is a byproduct of cost, age, and then access to opportunity. And so what could have been particularly helpful in this pandemic, when we're telling people to stay home, stay safe, and isolate, again, as the previous speaker said, you know, there are a lot of folks that are essential workers. So like all of our bus drivers, we all know Jason Hargroves, who passed away. We had at least we've had 11 city employees pass away, dispatchers, a police captain, several building safety inspectors, bus drivers. So it's really, you know, people who cannot do their work from home really were unfairly affected by this. So having this kind of digital inequity challenge problem in Detroit is a huge, huge issue. So much so that the Knight Foundation actually sponsored I have a digital equity and inclusion director, Joshua Edmonds, who has been working through the University of Michigan Center for Poverty Solutions to really try to help with this digital equity and inclusion. And again, we saw it yet again, and then I promise Mohammed I'll turn it over. We saw it again when all of a sudden kids could not go back to school anymore and everybody flipped a switch to online learning. And you had, again, think about it, 52% of people in Detroit don't have a wired connection, 40% don't have a data plan, and 29% have no connectivity at all. How are you supposed to learn?
Well,
Thank you.
thank you, Mr. Luck. Also, like, by the way, don't apologize, you know, for like anything like about time, you know, just speak your piece, you know, say what you got to say, you know. Like, I feel like because you guys are so experienced in the field, you guys probably have a lot to say. You guys probably know a lot too, you know. We also we have a bunch of students as the attendees, so, you know, might as well, you know, let them know a couple of things happening on the real world, not in the classroom. Let's expand beyond our bubble. So thank you, Mr. Bluff. Thank you so much.
Yes, thank you for that. Unfortunately, providers and policymakers are playing catch up with telehealth technologies right now. And we're just beginning to recognize that these are essential solutions for keeping, you know, potentially infected individuals out of hospitals and doctors' offices. Thank you for your insight. Our next question is for Ronnie. Ronnie, I spoke briefly about the All of Us research program earlier, and I know that I didn't get to highlight all of the wonderful things that this program truly aims to reach. So can you tell us how the All of Us research program is playing a role today in addressing health disparities? And also, if you can speak about the COVID-19 survey that the program has rolled out, what is the ultimate goal with this survey? And I also wanted to mention to our listeners, I forgot to mention earlier, that if you want to learn more about the All of Us research program, please visit joinallofus.org/together.
Take myself off mute. Thanks, Asra. I appreciate it. And thanks for having me here. I love the partnership that our team has with you and your team at Access. And so happy to be here and thank you for that. And, you know, you did a great job giving a high level overview of the All of Us research program. I can just say a few more things about it, then want to talk a little bit about data and disparities and pick up on some of what the previous speakers spoke about. And then if there's time, I think there'll be time, talk again at a high level, but just give people an understanding of the different ways that the All of Us research program is working to contribute our understanding of COVID-19. And this is all new and evolving literally as we speak, but it's really exciting to see how the program has been able to identify opportunities to contribute to this really important work. So as Asra said at the beginning, the All of Us research program is an effort to bring together 1 million or more individuals that agree to share their health information over time. The goal is to keep these participants involved for a decade or more. And the goal is, of those 1 million people, to work to build a participant community that truly reflects the diversity of our country. And this is really important when we define diversity as a program. You know, oftentimes when people talk about diversity, they are speaking about race and ethnicity. And not that that is unimportant, but diversity, as we all know, is much larger. There are so many different factors that go into making each person unique. And so when we at the All of Us research program talk about diversity, we actually refer to it as quadruple diversity. So what do I mean by that? I mean diversity of people, diversity of health status, diversity in terms of geography and data types. So in terms of people, the program is seeking participants from all backgrounds, all walks of life. In terms of health status, this isn't just a program where we're looking for patients and people who are sick or have some underlying health condition. We are seeking participation from people who are healthy as well as sick. In terms of geography, we want to make sure that this participant community includes people who live in urban centers, rural areas, wealthy suburbs, inner cities where there are a variety of factors that lead to disparities and health inequities. And also in terms of data type, we are seeking data from a variety of sources. So participants will be asked to fill out surveys over time to provide participant-provided information, to collect information on some of the social determinants of health that go into determining, a person's health status. Also, biological data from electronic health records, all of these things pulled together to really build a database that is richer and larger than anything that has ever existed before. Oftentimes when people hear about the All of Us research program, they think it's a research study, that they're signing up for a clinical trial or a research study. And really what the All of Us research program is doing is building the infrastructure, building the platform that will enable thousands of studies in areas that have not been possible before. And not just better understanding why some people get sick, but also understanding why some people don't get sick, why some people stay healthy. And so it's really exciting. I mean, for me personally, to work on an initiative that has the potential to be so transformative is really, really exciting. But I will say, and I've been working on this for 4 years now, the program just celebrated its 2nd anniversary, if you will. But we were working on this about 2 years before there was even a program, before the program was launched. And as exciting and promising and potentially transformative that this program is, we know that participation in research isn't a simple decision for everybody. And in fact, we know that many people are quite skeptical, and the barriers to participation are quite high, and for good reason, right? There have been unspeakable instances where there has been unethical testing, where research was performed under the guise of medical treatment, and lots of cases where whole communities have simply not been invited to participate in research at all. And so this is not an easy task. When we talk about building a participant community truly reflective of our country, we know that there are significant barriers that we as a program need to overcome to move community members from learning about the program to actually taking an action and committing to enroll in the program and stay enrolled over time. And so what we do know, in addition to the fact that there are these significant barriers, is that in order to ensure that we achieve this quadruple diversity, we have to create value and we have to build trust in each community. And that is going to look very different from community to community. And even when we go deep into communities, defining value and trust and working to have individual community members identify their why for participation is going to look very, very different. And so that's where groups like Access come in. And that is why when we first started working on this project, sort of core to our approach was the recognition that we needed to, number one, think about the communities we needed to reach and engage. And number two, then think about who were the trusted voices in those communities that could bring awareness of the program to their community members, and to help define value for each community. And so when we looked around the country, one of the things we have been working on for the past handful of years is to build out this national network of these trusted voices, trusted messengers and validators, people who can work with their communities. And so Access has been part of this effort with us, with our team, from the beginning. I think Madiha, I think it was you who was talking about the importance of data collection and the census. And I gotta say, you stole my thunder a little bit, because I wanted to talk about the impact that these community and provider partners have been making in the development of the All of Us research program. And I will use an example that I love because it's an Access example. Years ago, I think it was probably 2 years ago, one of the first things that you helped us understand is the undercounting, if you will, in terms of the data collection of Arab Americans, and what that meant in terms of services, in terms of research. And so after educating the program and our team, then you were able to work with the program to make sure that the program collects data on participants, and that there actually is a MENA category now that participants can select when they enroll. And so it may seem like a little thing, but it was actually quite significant. And I think our challenge now, to your earlier point, is now we need to educate the community why it's important when they sign up to select that category as opposed to selecting white. I think that's still a place where, for all the reasons you mentioned, we have some work to do. But the opportunity exists at the program level, but only because of your advocacy and your helping the program understand why that was important. And so I think it just speaks volumes. There are lots and lots of examples I could give as to how the community partners that we work with have contributed to program growth, and that's one of them. In terms of, I could talk all afternoon, but I'm sensitive to the time. So I wanna maybe talk for a minute about what the program is doing to help the understanding around COVID-19. And again, this is all really new, but I think really exciting. So the All of Us research program has initiated 3 activities to help better understand COVID-19 and inform current and future, I would say, pandemic responses. So the first is around antibody, and I'll go into each of these just again at a super high level. I'm not a scientist, and it always gets dangerous when I go outside my lane, so I'll stay super high level. The first is around antibody testing. The second is around a survey that is being sent out to participants to collect some social determinants of health information as it relates to COVID. And then the third is around the opportunity afforded by the sharing of participants' electronic health records, and what opportunity that looks like for researchers. So let me talk about the first one in terms of antibody testing. So by examining participants' blood samples, the program can actually add an important piece to the puzzle to learn more about the origins. This has to do with the origins and the spread of COVID-19 in the US. We started months ago thinking we understood when COVID-19 entered and where it entered and how it entered. But I think some of what we're beginning to see is challenging some of those initial assumptions. And so the way the program is going to be adding value, and I would add that this antibody testing initiative, I would say, is part of a massive global research effort. So other partners, it's not just the NIH and the All of Us research program. This includes the National Institute on Allergy and Infectious Diseases, Dr. Fauci's Institute. It includes National Cancer Institute, CDC, FDA, and other health entities from around the world. So what the All of Us research program is going to do specifically is test samples from at least 10,000 participants. We have over 300,000 participants at the moment. So take 10,000 who have joined the program most recently. So starting with samples from March of this year and work backwards until positive tests are no longer found. And we'll see what we learn. But everybody, the CDC is particularly excited about this activity. The second is this COPE survey that Asra mentioned. And this is the COVID-19, it's the participant experience survey. We refer to it as the COPE survey. The idea here is that the program has a unique opportunity to really understand how COVID-19 is impacting individuals. And not just individuals who have contracted COVID-19, individuals who are healthy as well. And to really understand the some of the issues that are impacting people and the way that people are responding to the pandemic. And there will be a survey sent out every month to participants. The first one just closed. So the second one will be sent out in a few weeks. It takes about, for a participant, about 20 to 30 minutes to answer the questions. And again, I think it will give the community a real insight as to the impact of this pandemic. Again, not just on people who have had COVID, but people who have had family members with COVID, people who haven't, but you know, are clearly changing the way they live and work due to the pandemic. And so really give us a deeper understanding. And again, this will go on month to month. And then the last one is related to the sharing of electronic health records. So as I mentioned, there are over 300,000 individuals that have enrolled in the program. Somewhere around 200,000 of them, I think there's 350 participants, and around 200,000 of those participants have agreed to share their electronic health records. And so if you think about it, that's 200,000 health records that researchers have access to help understand patterns of symptoms, illness, treatment effects, and, you know, perhaps even begin to unravel why COVID-19 makes some people very, very ill and some people recover. You know, looking at EHR records from a diverse participant base may help in that understanding. And so again, at a really high level, those are three of the ways that the program is working to contribute to understanding of things around COVID-19. So I'll stop there. I'm sensitive to the time. As I said, I could talk a lot longer, but I'll stop there because I know you have more you want to cover.
Thank you, Ronnie. Thank you so much. And thanks for the shout out. We honestly could not do this work without your leadership. And I want to give a shout out to Rima Matsumoto, who's on the call today also, and our partners at Henry Ford Health Systems as well, who are also on the call. So yeah, thank you guys so much for all the work that you do. I'm going to pass it back to Mohammed.
All right. So Ms. Tep just mentioned trust. And I wrote that big caps in my notes, just so you guys see. I wrote trust. And so the question is, to Ms. Tariq, is about mistrust in the community members and the medical system. And like, I'm an Arab American, I live in Dearborn. I witnessed it with the elders, like my parents 100%, my grandparents, my aunts, my uncles, you know, all of them have like this weird like stigma towards the medical system, but they all want their kids to be doctors, so it doesn't make any sense. You know, like that's just how it works. So Ms. Tariq, can you please like kind of like break it down or kind of like basically show us why the mistrust is so prominent and how it affects how like it even kind of may affect us negatively or positively in regards to COVID.
Oh, unmute. Okay, I got it. So a couple of weeks ago, I was at the testing site and I was talking to this lady who had come to get tested. She was getting retested because she had COVID a few weeks ago, and she was telling me how you know, she was very, very sick. She hadn't been sick like this before, but she didn't want to go to the doctor or to the hospital because she didn't want to disturb them. And I just thought about, you know, whether she, like, why she thinks that she would disturb the doctors. How many times in her past, maybe what she was either turned away or her pain or suffering was devalued, or she was just looked at in a certain way. That she came to that decision. And of course, I'm making a fleeting assumption here, but I also have some, you know, research to support some of this. We just actually, you know, we're in the process of, we haven't published fully yet, but we have a research study that we completed that looks at cultural centrality and discrimination, experience of discrimination, and its correlation with utilization of health care, specifically health prevention. And there's definitely a big link where people do feel that they're discriminated against when it comes to appearance or what, their beliefs or what they wear, um, and how that links to different health outcomes. So our initial data analysis does show a positive correlation between those things. And I will say, providers, they're educated as part of their education. They're taught to treat all patients equally. So, but the thing is, the patient sees a provider for maximum 15 minutes. If you're an efficient clinic, 10 minutes, right? Who else are they seeing during their 1.5 hour long visit? Are the intake people also trained to treat everyone equitably? Are the people who are at the reception desk trained for that? Is there specific training provided to them? So I think that it's really important to think about the bias check for every staff member that interacts with patients. That's one. The second thing is, policies. We have, we work with the immigrant and refugee community, right? They are coming, a lot of them are coming from very traumatic situations. And, some of them, have mistrust of all authority because of the situation of war or torture that they've been in. Sometimes being in a medical facility is re-traumatizes them, because if they were a victim of torture or survivor of torture, they were in a very similar facility getting tortured. So there's a lot of heavy baggage that some of these clients are carrying. On top of it, they come to this country to have a better life, to give a better life to their kids, but there's policies in place that further create this trust gap. I'll talk about like public charge. Okay, public charge means that if I'm applying, let's say I have a green card and I'm applying for my husband who's overseas to come here, or my family member that's overseas to come here, when I utilize health or utilize Medicaid or any benefits, I have to choose between my health and my family member, because that could count against my immigration case. Then you have things like Medicaid work requirements. So basically, you're not allowed health if you're not contributing as in the workforce. So it's like it makes health very transactional in this country. And I think that does not help the case of, building trust between the health system. Because from that, if I look at it from the point of view of somebody who cannot work and does not qualify for Medicaid because they weren't able to work, or they have to choose between their family member and their health, for them, they don't think that the doctor cares about their health. They think that the doctor cares about money, right? And that's not the case, because we have amazing providers, and hopefully some of the people in this, even in this audience, who are going to either become doctors or do provide service, with the most passion and care, but the system is painting them to be somebody they're not. Then on top of it, there's a new potential change that could come to the ACA that would mean that providers can choose not to provide service to somebody on the basis of their personal opinion or personal beliefs. Now, that does not help either. So I think, again, it's a two-sided thing where, we need to work with the community to help build trust. And I think that's what organizations like Access are there. We are the safe haven for these communities. And since the beginning, when we started doing this work, our biggest job has been to rebuild that trust and, subcontract with the government programs that we can provide them and like kind of build that trust. But then also, we need to fight the policies that are that are not helping, that are widening the gap of trust that exists. So I don't know if that kind of answers some of your question.
No, it answers it fully, actually. I think it's because it's a hard topic, because, I feel like elders teach their kids and the kids teach their kids, blah, 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 blah. And like, I guess you're right. The medical system does kind of mask the intentions of the medical professionals themselves. Thank you, Ms. Howard.
Thank you, Madiha. And you also mentioned something, sorry, I got a call, so my screen stopped sharing. I'm gonna go back to the questions. But you also mentioned something that is really important, is that doctors take an oath to treat all patients equally, and yet all patients are not treated equally. And yeah, it's really unfortunate. Our next question is also about trust. And it's for Beth. You know, as we know, African Americans and people with lower incomes, they're disproportionately misrepresented in COVID-19 cases and deaths. And now public health officials are calling for more extensive contact tracing. And we wanted to know that people of color and immigrants and refugees, et cetera, you know, they might be stigmatized. And we wanted to know if you think that these high-risk populations might be stigmatized. And in your opinion, is this the right strategy to use moving forward?
So, look, I think there is no question that there is an absolute distrust of government and institutions from people of color, and with real reason. I mean, we have, as a government person, we have not worked hard enough to keep trust. And so how, you know, as we go through this contact tracing and we do a lot of the things that we need to do from a public health pandemic perspective, how do we earn that trust? And one is, I think Ronnie and Medea talked a lot about it, is having trusted voices, partnering with trusted voices in the community, understanding the community and having people from the community who are doing the outreach. But we also have to, my hope, and this is probably naive, so just know that I can be a little starry-eyed every once in a while. My hope is that as public health officials and as people who are sworn to keep things confidential under HIPAA and what other laws apply, that it is confidential. And so, you know, and there's stiff penalties to pay if you breach HIPAA. So my hope is that we can earn trust back through being more educated about and have trusted voices within the community that will allow us to reach out better than we normally would. Although this is a huge, if we actually contact trace all the people that we're supposed to contact trace, it is a huge amount of contact tracing to do. So, you know, how we get, so we didn't have enough people within the health department to make all the calls out on test results before we automated a lot of it. And then we were able to take a lot of that just contacting folks. And so just getting the volunteers, taking them through all the HIPAA training, taking them through the training on how to have a really tough conversation with somebody who's COVID positive and what does that mean, and allowing enough time for questions and answers, and not, as Medea says, you know, when you talk about a very efficient clinic, they're like 5-10 minutes per patient, and that's just not the case when you're delivering a result to somebody. So how do you do that in a way that makes this more human? And then the other thing that we're dealing with is our, you know, deaf and hard of hearing population. So we don't have a lot of providers that are fluent in ASL. And so we really, I think the thing that this has done is showed us how bad we are. And we have to say, yeah, we're really bad, and we've got to take this and turn it and pull in all the diversity of resources so that we can do this in a way that honors the person that we are trying to serve.
Thank you, Beth.
Okay, so our next question was kind of mentioned, you know, since like the first question till now. is towards Mr. Dr. Hamami. And so essentially, like, knowing that the pandemic kind of exposed and it kind of made it, like, I guess, it made it mainstream now to talk about health inequities. It made it like even those people are saying on the news everywhere, and I guess like open new doors. So how can these doors kind of like give us? How can these doors open up new solutions for us to kind of reduce health disparities? And so it's a hard. I appreciate like this question is kind of hard to answer, but like, you know, what can be done? Like, where can we start?
I guess the question is, could it? The answer is it should, and it has to. It's something that we have been discussing and talking about for quite some time. And again, this pandemic exposed it, and it made it more clear that something has to be done. So there are many things that can be done, and we're not trying to reinvent the wheel, but these are things that now is the time to start put in motion. We all emphasized the need for data. So at minimum, when we are collecting clinical data and electronic health records and registries and all that, at minimum, it should capture race and ethnicity. It would be great if it also captures income level and insurance status and homelessness and food insecurity and all that. So the screening for social, what we call at Trinity, influencers of health, the social influencers of health, and establishing now a community profile for where some of those hotspots are so we can start addressing that. The second thing is something that, again, we talked about a lot in this hour, is trust. And not only trust, it's trust and communication. And that communication should be tailored towards the cultural differences when we're dealing with different populations. So one perfect example, one of our health, as you know, Trinity is a health system in 22 states. So we have different communities all across the US. But our hospital in Hartford, Connecticut is experiencing a lot of death and a lot of not only death from the disease, but a 200% increase in people dying at home from cardiac arrests or from chronic diseases. And when probed further, and this is a neighborhood that has a high percentage of African Americans, there is one ad, I think the ad council, that says, whether you have COVID or not, stay home, which to anybody makes sense, right? But to someone that might not have the educational level or someone who might be from a different culture, then you are telling me whether I'm sick or not, I should stay home, and that means I should not go seek help. So these are some of the things that have to be done, including education and all that. And finally, everything has to be tailored to the needs. So Madiha said providers should be treating people equally. And then she interchanged that with treating them with equity. Some of my students, I teach population health at the school, the College of Health and Human Services. We had a long online discussion the other day about equality and equity. So we do not approach communities with a sense of equality. We approach communities with a sense of equity. So community-based testing is a great thing. Drive-through testing is a great thing. But instead of drive-through testing, what if we do walk-in testings? That means those that cannot drive are not being disproportionately, or they do not have access. So everything has to be done based on the needs. And there are tons of opportunities that can be done. Finally, it is not a secret that those that are going to be affected are from a certain socioeconomic status, from a certain ethnicity, and being minority because of all the compounded risk factors that they have been experiencing for ages. The things that Madiha talked about, their occupation as being essential, lack of transportation, which is going to force them to take public transportation, and that increases their exposure to risk. Even when they are positive, going to a home, a one bedroom where they are sharing it with 6 and 7 people would not give them the quarantine or the isolation that is needed. So all those are things that we should address when we talk about disparities within the population and how the impact of this pandemic has been affecting certain ethnic minorities and immigrants and African Americans and Hispanics and so forth. And of course, if we are able to change that, and when it comes to COVID, then we can change every disparity that we can tackle across.
Thank you, Dr.
Thank you.
Hamami. Also,
Thank you.
good little quick shout out to all the professors in the chat and here in attendees. You got Dr. Hamami, you got Dr. Natalie Sampson, Dr. Patricia Wren, all professors at the College of Health and Education, Health and Human Services at University of Michigan Dearborn. They hold down the fort for all the students. You know, they help us out. They provide us with all the needs that we, especially like knowledge, you know, outlets. So thank you guys. Thank you, professors.
Yes, thank you guys. Our next question, and Dr. Hamami, those are really great points. Thank you so much for your insight. Our next question is to Ronnie. It was originally going to be, why is leadership from within these communities so important for ensuring that the response reaches disadvantaged populations? And I feel like we kind of did answer this throughout the webinar. So if you have anything more to add to that, please do. But also Dr. Susan Gold asked a question in the chat. Let me just go back to it. And I believe it was, is there somewhere where we can see the survey questions or the topics of each section? And that's, I believe it's in reference to the COPE survey of the All of Us research program. So yeah, I'm gonna pass it on to you.
Okay, sure. So I can take it in both parts. So if you are a participant, if you go, or if you want to become one, you can go to joinallofus.org/together and sign up, and then you will receive the survey. I believe it's, gosh, I don't remember how many questions, but I think it takes about half an hour. I don't have a copy that I can just send around. And like I said, it's going to come out every month. So they're going to look at, they're going to keep adding questions, and they're also going to look at the changes and answers to the same questions by the same participants to be able to assess the impact on a variety of factors to participants. The other thing I just wanted to add, I did talk a little bit about the importance of partnerships to our work, as my team works essentially as the connect between the All of Us research program and communities around the country. And so, you know, our job, we're tasked with helping the program build this participant community that's truly reflective of the diversity of our country. And we do that through partners like Access from around the country. But the other thing I didn't mention that I also think is important is the program has a set of core values, and it was actually one of the first things the program crafted when it was beginning to take shape. And so part of our job, I feel like, is to essentially hold the program true to those values, right? And we do that through our network of partners who not only bring awareness of the All of Us program to their communities, but then they bring back to us, and we bring to the program feedback, right? Feedback on program messaging, feedback on images, feedback on different assets, so that we can help the program understand, you know, the nuances and not so little differences between communities and within communities, so that there are materials and messaging that are going to resonate with the diverse communities that we're seeking to engage. The other thing that the program does that I think is really transformational and unique is to, and this again is to hold the program true to the core values that they set out around trust and transparency and quadruple diversity, is that there is a set of participant partners that have been integrated into the governance of the All of Us research program. And so these are individuals from all walks of life. There are a few dozen of them, I think 36 of them, from communities all around the country, who serve on internal working groups and task forces and the the steering committee, the director's advisory committee. And so these are individuals that provide sort of that real world perspective, again, from a variety of different communities who are literally, well, before we went digital, in meetings are literally sitting around the table with the leadership of the program, right? So they're sitting there with senior NIH leaders, they're sitting there with esteemed researchers. Their seat is, the same seat as the researcher next to them. And, they have the opportunity to speak up just as everybody else. And so, for me, being in those meetings and listening to the conversation at the very beginning of the program, and listening to the conversations that happen now, that there are these participant partners who are speaking up and pushing back or contributing, thinking about issues through a different lens, and having the program think about things a little bit differently, it changed the conversation. And so I think there is sort of that external network of community and provider partners that Access is a part of. But then there's also this internal participant partner work, that isn't necessarily, something that somebody would see. I mean, you can read about it on the website, but I do think it's important to talk about because it's directly influencing how the program is growing and evolving. So I just wanted to add that.
Thank you. So now I'm going to open it up for Q&As. And I just wanted to first thank all of our panelists and all of our participants as well. We really hope that people are turning to health experts at this moment to help them figure out new ways to make sure that that these longstanding and unjust barriers to health are addressed for the sake of not just the people who are facing these barriers, but really for our collective ability to be able to respond during a global pandemic. Hopefully there isn't another one. And so I'm going to unmute all of our participants. I know that we have a few questions already. Hamad, if you already want to kick us off with one of the questions as I work on unmuting everyone.
Yeah. For the questions in the chat, I wouldn't know. Honestly, my computer is like lagging super hard right now, so I'm sorry. But for now, I think can I just ask a question that I have?
Yeah, go ahead.
All right, cool. All right. Only because I'm a student, I need to know. All right. So this is, I know because you guys are all, in the field, in the real life, doing your thing. I guess so I found back to what I said about how I tried to tell my parents about no matter how important it is to kind of be a little bit rely on the medical system a little bit. They're not here to hurt you, they're here to help you. And I noticed there's a huge humongous generational barrier. It's in my eyes at least, it's enormous. What I see, what my grandparents see is crazy. So and this also kind of connects to with the A that All of Us Futures program is doing, and what IACS is doing, and kind of because you guys work with minority populations, and I guess you guys also focus on bridging that generational gap, or do you guys just focus on each generation as it is, or is that something that kind of deters people from also joining I guess medical research initiatives as well? So if you guys can answer that,
I mean, I think from the access perspective, when we see people, yes, we see individuals, but we also see families. So in our minds, client success is not that the client's own needs are met and now they're good. It's that the whole family is working well together and they're experiencing better health outcomes and social outcomes that will obviously in the end impact the client. So I mean, do we do specific programs to bridge the generation gap? Perhaps a little bit. I mean, we have some parenting classes. We do some community groups where parents, for example, for our substance use program, we have some family groups for domestic violence and some other vulnerable populations. But I think the bigger thing is that for us, when we see a person, we are also seeing them in the context of their family. So, you know, I think that's really important when you're serving somebody, because that will naturally help, you know, eventually bridge the gap. I don't think we're there yet, though. I mean, the population we serve is, you know, very transitional. Like a lot of new people come into this country on a regular basis. So the challenge still remains, and, you know, we're still kind of chipping away at it.
I think if I may add to that, Mohammed, if you allow me, it is not only how do you approach how do you bridge the generation gap. It is knowing your patient, knowing who you are encountering. I'll put another shameless plug to one of the classes that I also teach, Arab American Health. And one of the assignments that we discussed is you have a grandmother, and we're talking about an Arabic family, and those of you that are of Arab descent, you know that there is the grandmother, there's the mother, and then there is the daughter. And there are big hierarchy when it comes to what the grandma is going to say, what the mother is going to say, and finally the 16-year-old who is born here, and how do you trickle all those through the 3 generations. But you as a provider, when you understand each one and how to approach each one, you know, and it doesn't only apply for Arab Americans, it applies in every other, in the Hispanic community, the Asian community, the African American community. When you gain the trust of whoever you are dealing with, then this is where the gap becomes very little, if ever, and you are able to cross and make your point across. When I worked in Detroit at DMC, most of my patients were African-American babies, and I used to work in pediatrics. And I knew that no matter how much I educate the mother on what to feed the baby and when to introduce solids and blah, 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 and all that, nothing is going to register until I gain the trust of the great-grandmother, not only the grandmother, the great-grandmother. And once I gained her trust, then she would nod and tell her, yes, listen to the doctor, and everything was cool.
Thank you, Dr. Hamami. Our next question is to Ronnie. Ronnie, we have a lot of public health students that are listening right now. One of the questions is, what can students in this field do to help advance the mission and objective of the All of Us research program?
Take myself off mute. So thanks for the question. And, you know, as somebody said earlier, I mean, you know, I had said thank you to Access for inviting me. I didn't say thank you to all the students who are participating in the webinar for your interest in public health. I mean, it's really exciting to be speaking to all of you. It's really exciting to recognize that you're interested in this topic and interested in really helping to address health disparities, think about public health. I mean, you all are our future leaders and the next generation that's gonna hopefully help improve outcomes for all communities that shoulder a disproportionate burden in many areas at the moment. And so, you know, it's exciting to see that you're all interested in this. I would say in terms of what you as students could do, you know, in terms of precision medicine, when you think about delivering the right therapy to the right person at the right time, I mean, this seems to be the direction that medicine is moving and public health is moving. So I would just say continue to educate yourself in this area. I would say in terms of the All of Us research program specifically, you know, if I can make a shameless plug, you know, go to the website, read about it. If it's something that is compelling to you or to your families, then enroll. You know, there are lots of people who want to be spokespeople for the program, ambassadors for the program, but there's no substitution for enrolling in yourself and understanding what that experience is like. You know, how easy is it to navigate the enrollment process? What is it like when you go once, you know, doors are open again to the Henry Ford team and provide your biospecimen? What was that experience like? To be able to provide that personal perspective, you can't really replace that. So I would say if you are so moved and motivated, enroll yourself and learn more. And then I would say also, you know, reach out to local partners. There are incredible partners in Michigan and in the Detroit area. Access some of the other local organizations that Access is working with and supporting, the Henry Ford team. There are other local partners that our team supports that are active in the Detroit metropolitan area, and I'm happy if people want to reach out to me directly to find out who those other partners are. I'm happy to share those names. And if you are connected or want to be connected to any of these other local organizations, I'm happy to make that connection. You know, I think a lot of the organizations are always looking for individuals who want to volunteer their time to become local ambassadors. We are in the process of, you know, brainstorming about different tools that we can create for training and different things we can do to support the base of volunteers. So I think, you know, there are lots of opportunities depending on, you know, what it is that is motivating to you, how much time you have, you know, where your interest lies, et cetera. And then the other thing that this is definitely a whole separate webinar, but it may be something you want to think about if you're thinking about future topics as it relates to all of us, is there's a public data browser and there's a researcher workbench that is being rolled out by the program, so that as this data is de-identified and curated, the program is going to open it up to the research community. And one of the core values of the program that we didn't even have a chance to touch on today is, as we think about, you know, from the research perspective, making this data available and almost like, you know, working to democratize research, if you will, right? So making this data available to citizen scientists, to, you know, for STEM education, to teachers, to community members who may want to explore a research question that is relevant and important to their community. And so there are going to be new tools available to you as public health professionals to enable you to explore questions that you're passionate about. And so, you know, figuring out ways to understand what that looks like and how you can have access to that data could be really interesting too.
Thank you, Ronnie. I just want to be mindful of everybody's time. We have 3 more minutes left. If anybody wants to unmute their mic and ask any questions, please do so now. And we will also follow up with an email with the slides and also, for more information about the All of Us research program. So yeah, if you want to unmute yourself, please go ahead. And then if our panelists have any last words, you can share now.
I think I need to go back to school and get a master's in public health.
I think that, you know, as students are, you know, I mean, I don't know what year students are in this talk, but I think this is a great reminder, this pandemic and what's going on in the country, that when we provide service, that when we do research, we need to take a moment to check our own privilege. And really try to find a way to step in the toes of shoes of the person who we're trying to serve. And if we do more and more of that, I think the service we provide as public health practitioners, as researchers, will truly be impactful, and it'll lead to maybe getting one step closer to bridging the gaps that exist currently in our system.
I think I've always gave the example of the public health as well as primary care and you know, medicine. And for someone who has both feet in each field, we've always looked at public health as the last resort. And in times like these, it is not the last resort, it is the only resort. And these are one of the chances of bridging that and bringing the two disciplines together and ensuring that They do not contradict each other. They work in tandem. And it's really reasserting the role of public health as the chief strategist in health. And it's something that started a little while ago, especially with Public Health 3.0. But this pandemic and this crisis highlighted how everything should work together and re-emphasize the role of what public health should take. And it's quite amazing when you have not only those that are in the School of Public Health, but even high school students, even when I talk to my children, and they are now interested in knowing more about what does a health officer do, or what is an epidemiologist, or watching the old movies that Outbreak and Contagion and all that, and now linking it all together. It is truly amazing how, again, that's the silver lining that shows what role public health plays in.
Thank you, Dr. Hamami. And again, thank you to all of our panelists and all of our participants. We did record this webinar, so we will follow up through email and provide it to everybody who couldn't attend today. And yeah, and that's it. Thank you guys for joining us.
Thank you.
Thank you. Good night.
All right, stay safe. Thank you, everyone.